Hi, good evening, everyone. Welcome everyone to this clinical cardio class, 3C of Young Cardiologists. This is fifth lecture series in the series of 8 clinical case presentation and expert talk. And today we have Professor Dr. Sohan Sharma from SMS Medical College, Jaipur. Uh, uh, our resident, Dr. Prarthi from UN Mehta Institute of Cardiology, is going to be presenting the case. Today's clinical case presentation is going to be about a patient who presents with restrictive features of clinical cardiomyopathy, or it's a restriction versus constriction, the common clinical case scenario that's often asked, a case of constrictive pericarditis, and how do you differentiate that from restriction? So that's the clinical case that Dr. Prarthi will be presenting for an hour. Myself, Dr. Majan, who's professor and head of the Department of KEM Medical College, he'll be taking it along. And then we'll have the talk of our expert faculty, who is Professor Dr. Sohan Kumar Sharma. He'll be talking about the clinical cath and echo features of RCMP versus CCP. So, with that, as we await Dr. Jimarjan to join, we can start. And first of all, let me welcome Dr. Sohan Sharma. Sir, good evening. Dr. Sohan Sharma, sir, good evening.
Yeah, good evening, sir. Good evening, sir.
Yeah,
Sorry,
so we can start with Dr. Prarthi's presentation.
Yeah, definitely, sir.
Okay, so Dr. Prarthi is third year at UN Mehta Institute of Cardiology. She's a resident and she'll be presenting a case of constriction. Over to you, Prarthi. Can we have your slide sharing?
Good evening, one and all. Yeah, so are my slides visible?
No, Prarthi. Can you please click on share and share your slide deck? You can click on the share button first and start sharing your slides. Yeah, it started sharing now. Now the screen is fine. Okay, you can start.
Good evening, one and all. I'm Dr. Prarthi Shah, third year resident at UN Mehta Hospital, affiliated to BJ Medical College. Today, I'll be presenting a case of a 24-year-old male. 24-year-old male residing at Ahmedabad, Gujarat, from lower socioeconomic status, came with complaints of dyspnea on exertion since 6 years, abdominal fullness for 3 years, and bilateral pedal edema since 2 years. Patient was relatively asymptomatic before 6 years, before he developed breathlessness on exertion, which initially occurred while walking up to his house, approximately 1.5 to 2 kilometers, or even climbing 2 flights of stairs, which gradually progressed to breathlessness on doing household activities like taking bath and even climbing just one flight of stair gradually over the course of last 6 years. Breathlessness was relieved by rest and was not associated with cough or any expectoration, or there was no any seasonal variation. There is no history of breathlessness at rest or episodes of breathlessness immediately on sleeping or after 2 to 3 hours of going to sleep. Patient also developed gradual onset of abdominal distension, which he noticed around 3 years, approximately 3 years back, which was associated with feeling of abdominal fullness, especially at the flank region, which was associated with decreased appetite, fatigue, and nausea. The swelling was initially mild, but which gradually moderately increased, for which he had to get admitted, and he was given some injection to relieve the fullness. The relief was
So,
only
Prarthi,
temporary.
what is the mechanism of dyspnea? What is the mechanism of dyspnea in a patient from how does it differ in a patient with constrictive pericarditis versus, say, a valvular heart disease or, say, dilated cardiomyopathy? How is the mechanism different, or is it the same?
The dyspnea caused by a valvular heart disease is mostly due to increased pulmonary congestion, whereas in constrictive pericarditis, it is mostly due to decreased cardiac output, which in turn leads to
So what is
increase.
the cardiac output is actually reduced in a patient with constrictive pericarditis? If you measure
Sir,
in a cath, how much is the cardiac output?
Sir, the forward flow that a patient of constrictive pericarditis has is reduced as compared to other patients. That is
So
why
who has
patient
more
feels
reduction in
fatigue
cardiac
and
output?
decreased.
Dilated cardiomyopathy or restrictive cardiomyopathy? Whose cardiac output is reduced more
Sir,
for same
dilated
amount of
cardiomyopathy, sir.
symptoms? Right. So why are these patients then
Yes.
symptomatic on exertion?
Because first they have systemic congestion due to increased intracardiac pressures, and second due to low cardiac output associated symptoms of these patients, sir.
It's also the inability of the patient to increase and meet the increased cardiac demand on exertion. That's what is responsible for dyspnea. And what happens is the rising filling pressures because of the limited.
Yes, sir.
So because the limitation is increased venous return is mandatory, preload is mandatory to increase cardiac output. And because of
Yes.
constriction, the preload cannot increase beyond the limit. And that's why the afterload and the cardiac output doesn't go up. So it's inability of the cardiac output to increase in demand of activity. That's why these patients are often not breathless at rest unless they are compromised by involvement of myocardium. So can these patients develop dilated cardiomyopathy? Can a constriction have severe LV systolic
Yeah,
dysfunction?
yes, sir. In 15% patients of constrictive pericarditis,
What
there
is the
can be what.
mechanism there?
Sir, long-term constrictive pericarditis can cause myocardial. The myocardium is involved while the constriction does not allow preload. So it is a type of disuse hypofunction in a patient of constrictive pericarditis, wherein the LV on a long run, when does not receive any preload, undergoes a hypofunction, disuse hypofunction, which in turn leads to decreased systolic function.
What is this called as?
Sir, disuse hypofunction of
Also called as caged bird phenomena. What is caged bird
yeah.
phenomena?
Sir, in cage bird phenomena, whenever a patient undergoes pericardiectomy, after a very long period of constrictive pericarditis, the LV systolic function does not recover as it should be recovering, because it is for a very long time under the constriction of the pericardium. So there is an LV dysfunction following pericardiectomy, and there will be acute pulmonary edema following pericardiectomy, sir.
Sohan sir, any questions with regards to ODP? Sharma sir, any questions?
Audible, sir?
Sir, any questions you want to ask her?
Yeah, am I audible, sir?
Yes, perfectly.
Yeah, sir. I want to ask, means there's a dyspnea. After that, there is a abdominal distension and pedal edema.
Yes, sir.
So, is the sequence in constrictive pericarditis, or there is something different? Maybe sometime.
Sir, in constrictive pericarditis, ascites. Yes, sir. Ascites is followed by pedal edema. Ascites is usually the first symptom in patients of constrictive pericarditis.
Yeah. So, what is the mechanism of that ascites precox?
Sir, in constrictive pericarditis, basically there are two theories for heart failure, that is the underfilling and the overfilling theories. But in constrictive pericarditis, these theories, that is the increased sympathetic nervous system and increased decreased renal perfusion causing increased RAS system, does not work. Actually, the back pressure, that is the venous congestion, is the first mechanism that works in patients of constrictive pericarditis. And secondly, because abdominal veins, that is the veins are more in proximity of heart as compared to the peripheral veins. So there will be ascites prior to bilateral pedal edema in patients
What
of constrictive pericarditis. So due to the back pressure, sir, mostly.
what
And
is
there are other
hepatic weep?
mechanisms also. Yes, sir.
What is hepatic weep?
Yes, sir.
Hepatic weep phenomena in
Sir,
constriction.
in patients of constrictive pericarditis, patients will have ascites and involvement of the liver, but there will not be cirrhosis or late development of cirrhosis or the markers of cirrhosis, that is SGPT, SGOT, and
Weep
bilirubin will
is
not be so
crying.
much.
Weep. So weeping is that it's the other theory is that the lymphatics of the liver
Yes.
actually
Yes, sir.
spill over. So there is
Yes.
weeping from the liver, which leads to development of ascites. This was
Yes.
all theory before the McKinsey's theory came in. So lymphatic weep of the hepatic veins and the hepatic lymphatics as well, which leads to development of ascites. So what sir was asking, preceding what precedes what. So where does dyspnea fit in? So this is pretty clear that most of the patients of constriction will have ascites preceding edema. But dyspnea, does it precede, follow, or falls in between, or is the last thing to happen?
Sir, usually dyspnea occurs later than ascites and
No, dyspnea. So first symptom, as I was asking you and explaining, that it is the first dyspnea on exertion. Dyspnea at
yes,
rest is though late,
yeah,
but
late.
dyspnea on exertion may be
Yes.
the first limitation or first symptom because of inability to increase
the
cardiac
cardiac
output on activity.
Yes.
Just like in aortic stenosis. Okay, you may have dyspnea, but it's not with LV dysfunction always because
Yes.
it's a fixed cardiac output. Here again, the limitation is not at the level of valve, it is at the level of the which chamber. Which chamber is responsible for inability to allow earliest? Which chamber will not be able to accommodate?
Sir, LV, sir.
No. What is the LV pressure? Why should it be LV?
Sir,
If there is constriction, what chamber is the one that is most likely to be impaired in receiving the blood?
Sir, when the RA is receiving the blood, there
Yeah,
is
so RARV are the
yes,
one that is
yes,
more often
RARV, yes,
impaired because the pressure in the LV is much more than whatever the pericardium by adhesions or otherwise can constrict, right? So cardiac output is preload dependent. Again, I'm telling you. Can
Yes.
these patients do? So if you do a X-ray in a patient of dyspnea, you find what? Increased plethora, oligemia, or normal? These patients.
Sir, these patients will not have plethora. It could be normal, sir.
Right. So suppose you find plethora in a patient of constrictive pericarditis. What is your suspicion?
Sir, there is myocardial involvement.
Okay, that is one. 15% can have.
Second, there is in 1/3 patients there is pH of constrictive pericarditis, so there will be
pH, where pH causes plethora or oligemia.
oligemia, but
So?
With restrictive constrictive physiology, that is mixed physiology, there is pH. So
pH should not cause
with
plethora, no,
restrictive
Parthi. I'm not asking pH. I'm asking why should there be plethora?
Sir, in restrictive, first is due to myocardial involvement, and second due
Anything
to
else?
restrictive constrictive physiology, as in mixed physiology, if there is mixed physiology.
Or
I don't know, Prati, is there any selective constriction band or means any anatomical region of the heart that causes the plethora?
Sir, sorry, sir, constrictive.
Is there constriction band on any specific area that causes the plethora?
Sir, AV group, sir.
Yeah, left AV group. Sometimes
AV group.
there is a constriction that causes the means
Yes, sir. Constriction on the AV group
some
might
form
lead
of
to.
obstruction to the LV inflow.
Yes.
correct. So LV inflow obstruction at the constrictive, at the AV groove itself, the calcification may be enormous.
Yes.
Can pulmonary vein involvement cause pulmonary edema in constriction?
Sir,
Usual, unusual, rare.
sir, unusual, but
No,
can
it's very
happen.
rare. Why?
Because pulmonary veins are extra pericardial.
Absolutely. So I should think of anything else.
Yes.
They are extra pericardial.
Yes.
Right. How many sinuses are there in the pericardium?
Sir, oblique sinus and transfer, 2 sinuses.
What is its importance?
Sir,
Why should you know it in a case of constriction as a cardiologist? What's its importance?
Sir, these sinuses are the meeting points for the pericardium to cover the heart. As in, these sinuses they do not cover the left atrium. The big vessels are formed at these sinuses. So sometimes the left atrium, whenever there is constriction, these vessels, large vessels and the left atrium are uninvolved in constriction. So that is why it is important in sinuses. And
Also,
also
why
during
would
pericardiectomy, sir.
yes, that is important. So your surgeon wants to know. So
Yes,
that's what the transverses are used for. When they
yes,
lift the heart to remove then strip the pericardium off,
yes,
they want to put a snug in across the oblique sinus or a transverse sinus. If
yes,
they can lift it up and do a circumferential pericardiectomy, because otherwise it may be incomplete and you may not completely relieve.
incomplete. Yes,
So that is the
yes.
reason why the anatomy is important. Uh, yes, Dr. Sohn, any other questions from
I
ODP?
think I will proceed with the history. Right.
Right. Majan sir is here. Majan sir, any questions?
No questions.
Bhagirath bhai, good evening.
Good evening, good
Dr.
evening,
Solanki,
sir.
Professor Solanki is also
Yeah,
here.
thank you.
Okay. So we proceed further with history. Prarthi.
Just I want to clear one particular thing for the
Yes, sir.
student, that she was talking about a constrictive restrictive physiology producing the signs of pulmonary congestion.
Yes.
So actually the constrictive restrictive physiology is a mix of both. It is a mix of tamponade and mix of constriction. So it is a elastic constriction.
Yes.
So the physiology will not produce any symptoms of pulmonary congestion.
Okay,
It
sir.
will be having all problems related to the right atrial hypertension and some pressure on the right atrium, and it is like more of a combination of both. So absence of X, and so your X and Y will be equal and it will be like a M pattern. And the most important thing, the definition of constrictive restrictive physiology is in cath lab. So persistent elevation of RA pressure in spite of normalization of intrapericardial pressure is a constrictive restrictive physiology.
Yes.
Okay,
Okay, you
Prarthi.
can proceed.
Yes, sir. The abdominal swelling was associated with gradual development with bilateral lower limb swelling of feet for the last 2 years. The swelling was more during prone position and was less during prone position and was developed during upright position in the evening and tended to decrease on supine position and morning. It was not associated with puffiness of face, decreased urine output, and discoloration, reddish discoloration of the urine. Negative history, no history of chest pain, palpitations, cough, fatigue, giddiness, syncope, hemoptysis, no history of prolonged fever, skin lesions, joint pain, no history of hoarseness of voice, difficulty of swallowing, no history of limb weakness, altered sensorium, slurring of speech, pain in extremities or blackening of fingers, dimness of vision, or intermittent claudication.
So go back to your history. I mean, why do you really think this is a 24-year-old, 6 years dyspnea? Go back. Yeah, abdominal fullness and pedal edema. Go ahead now. Yeah. Next. Yeah. So what is your differential just purely based on this?
Sir, sir, in the past history, purely based on this, patient has right-sided heart failure along with breathlessness on exertion. So, left-sided. Since he's a 24-year-old male, he would it would be mostly rheumatic heart disease with left-sided obstructive lesion along with right-sided TR or TS, sir. But he does not have any PND or orthopnea that goes against this differential, sir.
Okay, congenital.
Yes, sir. Congenital could be one of the options like Epstein's anomaly or ASD, sir.
Yeah. So ASD, right.
Why
Why?
it
What
is
about
not a case
mitral?
of why it is not a case of pulmonary hypertension with RV dysfunction?
Sir,
PPH.
it could be pulmonary hypertension, but at this age, there should be severe symptoms
No, there
for the
is.
patient.
Patient has age. Age is fine. Age is not a problem. Something else is a problem. That's why it's not a PH. 6 years, no medication,
Duration of
survival,
6 years.
Duration of yes, sir.
natural
Duration of the
survival,
illness, sir.
and female to female, right? Ratio.
Yes. Yes, sir.
PPH,
Females are more
idiopathic.
likely.
Females
Yes.
are more likely.
Yes, sir.
Okay.
Why it is not a case of Epstein's anomaly?
Sir, yes, sir. One of the differentials can be Epstein's anomaly, but there should be bimodal involvement, bimodal
Need not
age
be.
group
Bimodal
involvement should
means
be there.
what? What is bimodal? Bimodal
Sir,
is that if you take 1,000 people, some
yes,
will present early, some will present late. Same patient
yes,
may not have two presentations.
yes, sir.
That is not bimodal. That bimodal doesn't mean that he should present twice.
Yes, sir.
So he can be the second part. I mean, okay, what
Yes.
you're saying is instead of 50s, he's come in 20s.
20s,
So,
yes, sir.
or he
So
should have
heart
come in
failure,
first decade.
sir,
Okay.
yes.
What else? Why else it's not abstinence?
Sir, Epstein's patients, again, they will present later, sir.
Do they present with something else? Arrhythmia?
Sir, they will present with.
Do they present with arrhythmia?
Yes, sir. With Epstein's will be associated with WPW or
That's
SV,
one. Or you can even, because of atria itself, you can have atrial
yes, sir.
fibrillation, right?
Yes, sir. Atrial fibrillation.
And
Uh,
cyanosis?
Yes, sir. Cyanosis will
If
be
you have an
present.
ASD, cyanosis.
Yes.
Or what else? Right
Uh,
heart, if it's presenting, does it happen? Does the
Can it
patient come with edema,
can it
ascites?
be case of severe pulmonary stenosis with RV dysfunction?
Yes, sir. It could be isolated pulmonary stenosis, but again, it is more common in females. And secondly, the patient will have associated features.
Okay, why not restriction? Let me put it the common differential that we are discussing today. I say this is RCMP, endomyocardial fibrosis, eosinophilic myocarditis. Why not? Or tell me how the presentation would be different from history point of view for this case to be presenting with our RCMP.
Sir, they will also present with right-sided heart failure, but they will be more symptomatic for a long duration. Like the patient has 6 years of duration of symptoms, so the patient would be more sicker as compared to a patient of CCP.
So,
First,
Prarthi, when you are asked why not this, you should always tell their symptoms which are specific for that disease.
yes,
So,
sir.
what does RCMP have which CCP does not have? Atrial enlargement, so
Yes.
atrial arrhythmias
Yes,
plus
sir. AF
clot
will be
formation plus embolic phenomena. So you
embolic
should
phenomena.
directly, when you are asked about history, talk about history.
Yes, sir.
Natural survival, where does he live? What would he present with?
Yes,
When
sir.
you are asking differential at history level, you should just think about them. So would usually be living in which country, which area, which state. That's how it starts, right?
Yes, sir.
More
Yes,
likely in Kerala,
yes, sir.
more likely presents with embolic phenomena, has atrial enlargement, so may present hypereosinophilia. If it is present, then may
Hypereosinophilia
have
is a
features
potential.
of the same.
Yes,
So
sir.
then you have skin rash, recurrent cough, breathe, itch, etc., etc. Right? And then embolic phenomena. So
Yes.
an arrhythmia. Again, arrhythmias. What arrhythmias happen in constriction?
Sir, AF can be present in 20% of patients of
Correct. But what
constrictive
about
heart
RCMP? How often do they get?
Sir, AF is present in 60% of patients. 60
Absolutely.
to
So
yes.
majority of them present with
Yes, sir.
arrhythmias,
Yes.
right? Okay. Majan sir, anything else?
Could it be a
Nothing else.
total anomalous pulmonary venous return?
Yes, sir. It could be total anomalous pulmonary venous
A
return.
PVO?
Sorry, sir.
Yes. Same. Total anomalous pulmonary venous return.
But again, sir, there will be cyanosis in the patient, and they will present earlier than the age group of 25, sir.
So instead of total, what is more likely? Partial.
PAPV, sir. Yes, sir.
Partial.
PAPVC, yes.
ASD with PAPVC may present like this. But again, right heart failure.
Yes.
Sometimes Budd-Chiari syndrome present like this. So it is one of the differential diagnosis of this type of presentation.
Yes, sir.
So some of these patients, as Sir Majan sir is saying, may actually present in a reverse way. You have a post-hepatic etiology for cirrhosis.
Cirrhosis.
Right. So these patients can be Budd-Chiari, can be constriction, can be RCMP, all of them. And then retrospectively, you end up with a cardiovascular etiology as the diagnosis of cirrhosis. Okay. So now negative histories, past history. Kaya, what was significant there?
6 years back, he was admitted to UNM with breathlessness on exertion and was diagnosed to have fluid around his heart, which was removed by inserting a needle, and was diagnosed to have tuberculous pericardial effusion along with pulmonary tuberculosis, for which he was started on AKT. He was relatively symptom free for 3 to 4 months, after which he again developed similar symptoms. Otherwise, there was no other significant past history, and family history is insignificant.
Okay, summarize.
So 24-year-old male came to UN Mehta with complaints of shortness of breath on exertion since 6 years, with abdominal distension since 3 years, and pedal edema since 2 years, with past history of pulmonary and pericardial COX. AKT was taken. My first differential diagnosis is constrictive pericarditis with or second core pulmonale with right-sided heart failure, sir. Rare differential diagnosis could be congenital, like abstinence, ASD, PAPVC, or primary PH, sir. But since, sir, he has a very...
So you said tuberculosis history.
Yes, sir.
How
He has-
often is it found in Indian? So what is the commonest etiology across the world of CCP and commonest etiology of CCP in India?
Sir, in India, it is tuberculosis, approximately 38 to 83%, as per one Asian series. And across worldwide, it is idiopathic, that is so it could be post-viral or post-surgery or post-radiation, sir.
Right.
Approximately 8 to 10%, sir.
So can you tell me some multi-system disorder which can present with constriction?
Sir, one of the rare syndromic association could be there with constriction, that is mulberry nanism.
Mulberry nanism would not come so late. Usually these are fatal.
Yes, sir.
What is it? Mulberry nanism. What is it?
Sir, it is a syndromic association in which muscles are involved, as in mulberry stands for muscle, constrictive pericarditis, involvement of like cataracts and iridial involvement, that is eye involvement.
NULI,
Yes, eye
PR,
involvement,
EY.
liver involvement,
Liver.
and
PR is
constrictive
brain.
pericarditis.
Brain and eye.
Yes, sir. Brain
MU for muscle,
yes,
LI for liver,
liver and
PR for brain,
brain.
EI for eye. Ulibre.
Eye. Yes.
Ulibre, nanism. Nanism means
Sir, short
stature.
yes.
And of course, they come with constriction. Rare,
Yes.
usually fatal in first year of life. So
Yes,
unlikely to
first year.
present. Yeah, in this age. But any other autoimmune disorder which can cause constriction?
Sir, amongst autoimmune disorders, rheumatoid arthritis is the most common to cause constriction.
Correct.
Approximately 18% of patients of rheumatoid arthritis can present with constriction.
Right. SLE, can it cause constriction?
Sir, other autoimmune disorders very rarely cause constrictive pericarditis. Like in SLE, it is only 3%, sir. And
So
gout.
SLE more likely presents with what?
Sir,
Which layer of the heart is involved?
Sir, myocardium and
Endocardium.
endocardium.
Limb-sex
Yes.
endocarditis.
Yes.
So
yes,
SLE
limb.
more often causes limb-sex endocarditis.
Yes,
Even
sir.
more common than that is
Uh, see, mitral valve, sir. Mitral valve involvement. Yes, sir. Sir.
okay. Go ahead.
Any drug causing the pericardial involvement or constrictive pericarditis or
Sir, anthracyclines, bleomycin, and dasatinib is known to be causing constrictive pericarditis.
Yeah.
And other than that, hydralazine and yes, sir, hydralazine.
Okay, go ahead.
On physical examination, patient is conscious, cooperative, well oriented to time, place, and person, fairly built, poorly nourished. Height is 169 centimeter, weight is 43 kilos, BMI of 15. Patient has pitting edema on feet, present bilaterally. There is no pallor, icterus, clubbing, cyanosis, lymphadenopathy, back and spine are normal. Temperature is normal by palpation, pulse is 96 per minute, regular, normal in force, volume, and tension. Bilaterally symmetrical with no radial and radiofemoral delay, normal condition of the arterial wall without pulse apex deficit. BP is 106 by 80 in the right upper limb, 100 by 78 in left upper limb, and 100 systolic in both lower limb. No evidence of pulsus paradoxes. JVP is pulsatile with mean JVP pressure being elevated 8 centimeter above the sternal angle at 30 degrees with rapid X and Y descent with no inspiratory fall in mean JVP. Respiratory rate is 18 per minute, thoraco-abdominal. Sir, just a second, sir.
Yeah, connect the laptop to charger.
Yeah, Prati, how you see the apex pulse deficit in this patient? Is how you analyze the apex pulse deficit?
So just a minute. Yes, sir.
Sir was asking pulse apex deficit. How do you measure alone as an examiner?
Sir, your voice is not audible.
Am I audible?
Yes, sir.
How you examine the apex pulse deficit means?
Sir, in apex pulse deficit, we keep our stethoscope on the apex and simultaneously measuring the pulse at the radial artery, wherein we will calculate the number of dropped beats, and if it is more than 10, it is suggestive of an apex pulse deficit, sir.
So is there any need, really need in this patient to see the apex pulse deficit because the pulse is regular?
Yes, sir. Because sir, CP can be associated with AF in 20% of patients.
No,
That
but
is
if
why.
it is regular.
Because pulse is regular, it is not required, sir.
No, it is
How
still
you
required. That
means?
is the whole question.
Yeah.
Yes,
Why is
sir.
it still required? Why is it still required? Indirectly tell me causes where there is regular pulse, but there is AFib. Can you
Yes,
hear
sir.
me, Prarthi?
Sir, I can barely hear you, sir.
Atrial fibrillation with regular pulses.
Yeah, sir, atrial fibrillation with complete heart block or digoxin toxicity, sir. or patient has been given digoxin in or atrial fibrillation with very fast rates, sir.
Yeah, how you see the pulsus paradoxes? Second is no evidence of pulsus paradoxes.
Yes, sir. For pulsus paradoxes, we need to first attach a sphygmomanometer to the patient, and we go up to the systolic pressure, and we slowly come down by 2 mmHg per second, the rate of 2 mmHg per second, wherein we will see where is the where do we first hear the coronary cough sound in expiration, and then we will see the when we'll hear in inspiration and expiration, that is both phases, and the difference between that is considered to be the pulsus paradoxes, and if it is more than 10, it is considered to be positive, sir.
Have you ever done this maneuver to any patient? Means have you ever measured the pulsus paradoxes? It's practically.
Yes, sir.
Have you ever done it?
Yes, sir. Yes, sir.
Because it's very difficult to measure the pressure and see the respiration. It's really a difficult task.
Yes, sir.
So you drop down the sphygmomanometer pressure 2 mm of mercury per second,
Yes.
and you just auscultate it. There is intermittent pulses, intermittent auscultatory sounds are there. Then they become regular in the both phases of the respiration.
Yes, sir.
That you can appreciate. Yeah.
Yes, sir.
How much drop is significant?
Yes, more than, sir, 10.
Okay. It is seen in which conditions?
Sir, it is most commonly seen in cardiac tamponade, sir. Other conditions like COPD can also have pulsus paradoxes, sir.
And constrictive
Severe asthma.
Yes, sir. In 1/3 cases of constrictive pericarditis, patient will have pulsus paradoxes, sir.
Right. What about the JVP? Means in waveforms, so rapid action, wide descent. What does it mean?
So rapid X and Y descent means that first rapid X descent, because the atrial pressure is elevated, so there will be increased flow of blood from RA to RV, causing rapid X descent, and rapid Y descent is due to there is increase in the intrapericardial pressures, so there will be rapid decline in the end diastolic pressure of RV, causing rapid Y descent, and it will cause a dip and plateau pattern wherein there will be
I'm not
filling.
able to, Prati, just a minute. I'm not able to understand. X descent is which event? Is a systolic event or a diastolic event?
Systolic event, sir.
X is a systolic event.
Systolic.
Y is a
Diastolic event.
systolic or late systolic event? Y descent.
Sir, Y is early diastolic event. So there will be
So
filling
it's
in
a
early
early
diastole
diastolic
only.
event. So in the early diastole, there is a
Yes.
rapid filling of the ventricle. That's why
Yes, sir.
it means
Causing
Y descent.
rapid Y descent, but when the intrapericardial pressures will equalize the intracardiac pressures, there will be no further filling in diastole, and there will be stoppage of blood filling, thereby causing dip and plateau pattern, sir.
Yeah, it's fine. And if suppose Y descent is not seen, so what are the differential in restrictive cardiomyopathy? Is there any difference in JVP?
Sir, in restrictive cardiomyopathy, there will be rapid Y descent, but it is variably seen in restrictive cardiomyopathy, whereas in constrictive pericarditis, it is mostly present, sir.
What do you mean by no inspiratory fall in mean JVP?
Sir, usually on inspiration, there will be inspiratory fall in the JVP due to decrease in the pressures. But whenever there is constrictive pericarditis, there is no decrease in pressure. That is why there will be no fall in JVP during inspiration. Thereby, the sign calling it Kussmaul sign, and it will be present in constrictive pericarditis as well as restrictive cardiomyopathy, sir.
Okay. What about the tachycardia? Is the tachycardia is there in this patient or not? Because patient is so much so symptomatic.
Sir,
Pulse.
usually sinus tachycardia is present in patients of constrictive pericarditis because of decreased cardiac output. So it could be present, but in this patient, a patient was already decongested till the time he was examined, and he was stable and hospitalized. So the heart rate is almost 96. On admission, it was 120, 130.
Why so? Why? What does this heart rate tell you?
Sir, it is a
What does the
compensatory.
heart rate tell you?
Sir, it is a compensatory mechanism of patients of constrictive pericarditis due to decreased cardiac output. So it should not be
So,
there.
what are the drugs contraindicated in a patient presenting with heart failure with constriction?
Yeah, so CCBs should not be given in such patients, or beta blockers to control the heart rate, sir.
So, how do you control the heart rate in these patients?
Sir, by decongesting the patient and by giving diuretics, sir.
And if the patient has AF,
Yes, sir, and controlling the heart rate, sir.
no, no. What do you control it with? If you can't give CCB, you can't give beta blockers, and patient
Sir,
has AF, what is the drug of choice?
sir, digoxin and yes, sir, digoxin.
Digoxin.
Yes. Yes. Should I move forward, sir?
Yeah, go ahead.
Chest is cardiovascular examination. Chest is ellipsoid in
So,
shape.
so by JVP, can you differentiate constriction from RCMP?
Sir, there will be prominent Y descent, X and Y descent in constrictive pericarditis, but in restrictive cardiomyopathy, the atrial muscle is involved. So the
Atrial
X
muscle,
descent,
ventricular muscle.
atrial and ventricular muscle both are involved. So the X descent, which is mainly due to the ventricular negative pressure and decrease in dp by dt
Simple,
of the
Prarthi, you just don't complicate too much. Simple. What is the PA pressure in RCMP?
Sir, it is more than 50, sir.
So pH हुआ ना, so pH, what is the finding?
Sir, there will be as in JVP, sir.
Of course.
Yes, sir. Prominent A wave with
Okay, and what happens with TR?
TR.
Does it
There will be
involve
CV
so
waves.
when muscle is involved,
Yes,
when
there will
muscle
be
is
CV
involved,
wave with
myocardium is
rapid
involved, so
vibration.
there'll be TR, so TR. So that's
TR.
simple, no?
Yeah.
Loss of, so TR causes which wave to disappear?
Sir, loss of X wave, sir, in patients of
Correct. So that's very
TR.
simple, no? So
Yes.
don't complicate too much.
Yes.
Don't think simple, keep things simple. Okay,
Yes.
go ahead.
Yes, sir. Chest is ellipsoid in shape with bilateral symmetry. Precordial shape is normal. Apex impulse is diffuse. There is systolic retraction of the left fifth at the left fifth intercostal space in mid clavicular line. No other parasternal, suprasternal, epigastric back impulse is visible.
So why apex is diffuse?
Sir, due to involvement, there is a systolic retraction of the
That
apex.
doesn't make apex impulse diffuse. Diffuse always means
RV
either
in
aneurysm. If it is
yes,
LV, then it is aneurysm or it is RV.
RV, yes, sir.
Okay.
RV.
So it's more of the retractions that matter. So
Yes, sir.
I think apex impulse diffuse in an RC, MP or CCP. RCMP you can think of in terms of actually what happens in RCMP. Can you appreciate the apex?
No, sir, because it would be diffuse due to RV
No, it is
hypertrophy.
obliterated.
Yes,
It
sir.
is obliterated. There is
Yes,
nothing like apex.
yes, sir.
And especially which apex? RV apex. How do you
Yes,
palpate RV apex?
sir. There.
Subcostally with
Yes,
your thumb. You
yes,
put in the Ziphi-sternum and try to palpate, you'll not be able to get a pulse. In the Ziphi-sternal angle, in the subcostal angle, when you try to push your thumb, you may not feel anything because the apex is completely, RV apex is completely obliterated if it is RV RCMP. LV apex may or may not be palpable again because if the LV is involved. But diffuse, it's very unusual. Okay. If it is diffuse, then probably you're dealing with something else. I mean, in RCMP, what you are looking at is impalpability of the apex. While CCP, you're looking at retraction. Now, again,
retraction.
space versus ribs versus whole costal. What is the difference of these retractions? Systolic retraction. From this statement, can you make out it by what age he developed constriction?
Sir, that is, if fifth intercostal space is involved, then he already has
It's
developed
not
constriction.
fifth. No, it's not the fifth. It is about
Fifth
before
is,
the costal cartilage fuse. If
yes,
he had a constriction, which you were mentioning his childhood and history and pericardial tapping, etc.,
yes,
if
sir.
it had developed before it, then
Yes,
the
sir.
retraction, usually because of the adhesions, would also cause the not only the intercostal space but even the ribs drawing.
Yes, sir.
The way you have the deformities also explaining a congenital heart disease, same way the retractions, whether it's only the space or the rib along with it, would tell you at what time the adhesions develop.
Yes, sir.
Am I getting?
Yes, sir.
Are you getting the point?
Yes, sir.
Yeah. So this probably has happened like 6 years history. Probably has happened after the costal cartilages have fused. When do the costal cartilages fuse? Why by
Sir,
what age?
sir, at the age of 5 years, sir.
5 years.
3 to
Sure.
5 years.
Anterior end or posterior end?
Uh, Sorry, sir. I don't remember.
Costal cartilages are only present anteriorly. No? The fusion takes
Yes,
place posteriorly.
yes,
The ribs are actually confused, fused
yes,
not with the cartilages. There are nothing in the posterior.
yes, sir.
Okay.
Anterior. Yes, sir.
Um, okay. So there is Go ahead. Pericardial knock.
Yes, sir. On palpation, findings of inspection are confirmed. Apex beat is diffuse in the fifth and sixth intercostal space. There is a palpable pericardial knock present at the left intercostal space at mid clavicular line. No other palpable heart sounds, thrills, heave, or rub is present. On percussion, upper border of liver dullness is present in the right fifth intercostal space in mid clavicular line. Left heart border corresponds to apex. Right heart border is substernal, and left second intercostal space is resonant. On auscultation, S1 is normal, S2 is normal in intensity and is widely split. There is no S3, S4, opening slap or click. High pitched early diastolic sound is present over the left intercostal space at the mid clavicular line, best heard with diaphragm of stethoscope with inspiration, suggestive of pericardial knock. No other murmurs are present.
Karthi, what is the difference between S3 and pericardial knock? Is it the same thing? It's a different.
Sir, pericardial knock is a high pitched sound, so it can be heard by the diaphragm, whereas S3 is
It's a
a
description of the sound. Means practically it's a S3 only.
yes, sir.
It's a S3 that is heard in constrictive pericarditis and is a
Yeah.
loud sound, high
Yes,
pitched sound that is
yes.
known as
Whereas it is
pericardial.
a S3 is a low pitch sound.
So no S3 is not the right word. Means it's a
Okay, sir.
pericardial knock with
Okay,
along
sir.
with no S4 and opening snap or anything.
Okay, sir.
Yeah, go ahead.
Liver is palpable 3 fingers below the right costal margin with a span of 16 centimeter. Spleen is just palpable below the left costal margin. Horseshoe shaped dullness is present, suggestive of moderate ascites, and in respiratory system, presence of dull note over the right seventh and eighth intercostal space at anterior axillary and posterior scapular line. Auscultation reveals decreased breath sounds and tactile vocal phragmectus on the right side with bilateral coarse crackles and egophony present. And in the CNS examination, it was normal, sir. Yes, sir, should I move forward?
Yeah.
So my final diagnosis is a structural pericardial disease in the form of chronic constrictive pericarditis of tuberculous etiology, currently in NYHA class 2 with CCF in normal sinus rhythm, without pulmonary arterial hypertension with no evidence of infective endocarditis.
What about the ascites? It is a
Yes, sir,
part of
and
CCF, no?
involve and
Bilateral
yes, sir,
effusion
yes, sir,
ascites
and
was
ascites.
described like that.
Yes, yes, yes. Right-sided pleural effusion and ascites, sir.
Yeah, I think from diagnosis point of view, it's okay.
So, Prarthi, can you hear me now? Am I audible?
Yes, sir, you are very well audible.
Yes, sir.
Pra-
Yes,
yeah,
sir.
Prarthi.
Yes, sir.
So can you explain the mechanism of effusion again?
Sir, due to sir, firstly, the patient already had pleural pulmonary cox. So, firstly, it could be due to recurrence of the pulmonary cox. Secondly, it could be due to constrictive pericarditis per se, which due to increased back pressures causing pleural effusion, ascites, and bilateral pedal edema, sir. And thirdly, it could be hypoalbuminemia or increased lymphatic congestion in patients of constrictive pericarditis, sir.
Right. So how do you treat him? What is your plan of action?
Sir, first thing is medical management for this patient.
Can we
First,
see the ECG?
yes, sir.
Medical management se pehle
Yes, yes, sir. ECG,
confirm the
X-ray.
diagnosis.
Yes, sir.
So
Yes,
show
sir.
the ECG and
X-ray,
X-ray.
and yeah.
So what are you
Every-
expecting in ECG?
Sir, constrictive pericarditis consists of non-specific STT wave changes, along with there could be
Do you have
RA.
ECG? Do you have ECG for this
Yes, sir.
patient?
Yes,
Can
sir.
you show? Yeah.
Yeah, this is a 12-lead ECG with normal sinus rhythm, with P pulmonale, along with with T wave inversion in V2 to V6, sir.
So P pulmonale suggests what?
With Q wave. Sir,
So I
atrial
say
enlargement,
this
sir.
is RCMP, PH, and pulmonary hypertension. Tell me why it is not. I say this is pulmonary arterial hypertension, and hence you are dealing with RCMP, not a CCP.
Sir, but if it is
What is the
pulmonary
axis?
sir, it is right axis deviation. Almost, almost 7.
No.
Yes,
At
sir.
least if you can look at the QRS axis and the
QRS.
ECG it is printed, it is not right axis. How come it is right axis? One is equiphasic, ABL is also equiphasic.
AVF is also
2, 3 AVF are positive.
Yes, sir.
So it's normal axis. So right
Normal,
axis is not there.
approximately. Yeah, sir.
Yeah. And
Approximately
what about
18.
the RV forces? What about RV R in V1?
Sir, it is QR. So RV is there is RV involvement, sir.
So if you have R by S, no. So if there is RV involvement, then it is RCMP, no? That's the whole
Yes.
point.
Yes, sir.
I'm saying you have to contradict me, no? You have to justify your own diagnosis. If that is the case, are we dealing? So this is not classical
This is
CCP.
not. Yes, sir. But there is a small RS R dash.
And where? Then so what is in presence of RS R dash? What should be the voltage of R for RVH?
Sir, for in presence of incomplete RBP or RS-R dash, it is 11 R wave of
Correct. So
11,
it is not,
sir.
right? It
Yes,
is
sir.
barely 7,
7.
which
Yes,
even
sir.
without otherwise of RS R dash, it is not
Yes.
qualifying.
Yes,
so
sir.
no RVH.
Yes.
P pulmonale you can explain with pulmonary Cox pleural effusion
Yes, sir.
or a vertical heart.
Yes, sir.
T inversions, non-specific. Axis
Non-specific.
normal, so probably not an RCMP. That's how you can counter that it
Yes,
may
sir.
still be a CCP despite P pulmonale. Right.
Yes.
So let's look at the X-ray. So
Yes, sir.
if the X-ray shows lung abnormalities, then still you can qualify this ECG not being a CC or
Yes, sir.
RCMP. So what is the X-ray? See, you
Yes,
have
sir.
lung involvement.
Yes,
Do you
sir.
think the lungs are okay or not okay?
No, sir. There is lung involvement in the form of fibrosis and right-sided pleural effusion, sir.
So you don't. This is not pulmonary plethora, right? We were
Yes, sir.
discussing.
It is. It is.
You don't expect lungs to be white at
Yes, sir.
least in a patient of CCP,
Yes, sir.
unless we discuss couple of things that can be the cause. So either it is a RCMP or it's a lung pathology along with a CCP,
CCP. Yes, sir.
right? Okay, what else tells you that this is probably lung pathology, not a congestion, not a plethora? Why it's not BVM?
Sir, there is crowding of ribs
Very
along
good.
with.
Very good.
Yes, sir.
Trachea, Where is the
And there's
trachea?
a tracheal shift also. Yes, sir.
To the right. So there is
Yes, sir.
underlying pull on the
Yes,
right,
pull
right?
to,
There is a pull
towards
to
right,
the
sir.
right.
Yes,
There is
sir.
lung pathology there.
Yes, sir.
That's the reason why you're getting P pulmonale. So you should have anticipated and be bright. When you have seen X-ray, at least for this case presentation, you
Yes,
should
sir.
have thought to correlate that with an ECG.
Yes, sir. Yes, sir.
Sohan sir, Majan sir, any questions on X-ray ECG?
Yeah, anything you are more expecting in the X-ray means any calcification or like that?
Yes, sir. There should be pericardial calcification in such cases, sir. But
So
it is,
you
Where
want
would
to
you
show some
anticipate?
other view of X-ray, which is okay with this X-ray chest
sir,
view?
lateral X-ray is better for seeing pericardial
Have you
calcification.
done it for this patient?
No, sir, it was not possible in that patient, this patient, because it was already he was getting discharged. So at that time, it was not possible.
But that should be done, right?
Yes, sir. Yes, sir.
Okay. Move to echo. So again, Prarthi, before you do an echo, what are you expecting? What are you
Sir,
anticipating to confirm your diagnosis? Couple of
sir,
things,
I
just
will.
small, important, three things on echo, three important things. There are 20 of them, just three things. 1, 2, 3.
Sir, respiratory variation across the mitral valve and the tricuspid valve. That is first
Okay.
thing I would like to see.
One.
Second, yes, sir.
Yes, that's one. Second,
Yes. Second is medial E prime. That is more if it is more or less than the lateral E prime
so
or
muscle
greater than 9
involvement,
prime. Yes, sir.
respiratory variability. And third,
Yes. And respiratory variation across the hepatic veins.
that's respiratory all across. You've
Yes,
said
sir.
so, covered everything, no?
Yes, sir.
Respiratory variation in hepatic, tricuspid, mitral, all. Then
Yes, sir.
you said
And biatrial involvement, sir. That is
atria will
atrial
can be
enlargement.
enlarged. It can be
Yes, sir.
enlarged. Muscle involvement in form of.
Yes.
So muscle involvement in
Medially,
form of. So
medially, that is the
regurgitation,
tissue
annular
Doppler.
dilatation, and tissue Doppler. Correct.
Yes, sir.
SM,
Tissue
E
Doppler.
by E prime.
And septal movement, sir. Septal.
So that is all muscle
shut.
involvement.
Yes.
All are
Yes,
muscle
sir.
involvement.
Yes.
And third, pressures. What pressures?
Sir, that is PA pressures, sir. PA pressures should not be more than 15 patients of constrictive, whereas in restrictive it is more likely to be more than 50, sir.
And if you can get end-diastolics, can you get end-diastolics?
E by E prime, sir.
No. E by E prime correlates.
Yes,
If
sir.
the patient has got some regurgitant lesion, can you
Yes, sir.
estimate enda?
Yes.
So
Yes,
things,
sir.
simple things, no?
Yes, sir.
E by E prime is a study. E by E
Yes.
prime is a study where X value of E by E prime, how much correlates with what EDP?
Sir, more than when E by E prime is more than 15, then it correlates with the LVDP of more than 22, sir.
So that's a correlation.
Yes,
But
sir.
if you get, say, PR, AR,
Yes,
then
sir.
you can
And
easily get,
PR,
no?
sir.
You
Yes,
can
sir.
just put
Yes.
an AR Doppler,
Yes, sir.
get the end diastolic.
Yes,
So
sir.
what are you expecting in a patient with CCP versus RCMP
Sir,
for end diastolics?
Sir, the end diastolic pressures will be elevated in patients of CCP, but TR will be less likely seen in patients of in the CCP as compared to RCMP, sir. And again,
TR will
the
be less or more.
equalization of pressures of
So that's more
LV and
important.
RV.
End diastolic equalization. At the end of
Equalization
diastole, you expect all pressures to be equal.
Equal.
And what
And
about one third?
elevated, sir.
Rule of one third?
Yes, sir.
What
RVDP will
one third?
be more than 1/3 of RVSP, sir.
Correct. So
Yes,
so three things that you look for: muscle involvement, pressures, and respiratory or hemodynamic changes,
yes,
right?
sir.
So
Yes,
that categorizes practically majority things. So Ansar is going to take detailed lecture on that. Okay. Anything else on echo? Show me the echo. You have taken echo images.
The IVC was dilated in this patient with less than 50% respiratory variation. This is the plaques view showing no atrial enlargement, that is normal atrial sizes, and with normal LV function, with septal bounce in this patient, sir. Sir, this patient was not so much cooperative during the echo, so that is why we could not do further studies in this patient, sir. Actually, I wanted to take hepatic flow reversal in patients in this patient, but I could not get, sir.
Have
This
you
is
taken
the
Doppler signal?
yeah, sir. I could not get it. He was not
No issues.
very cooperative, sir.
No problem, sir. Will show.
Yeah.
So yeah,
This is
so that's there.
the
Yeah, it
yeah,
is there, no?
across the tricuspid wala
That is what I was asking.
yes,
Okay.
yes, sir. But there was no variation across the mitral valve, which was not possible to see. Sir, it could be due to decongestion. There was
Volume
no
dependency. But
yes, sir.
tricuspid
Yes, sir.
showed, right?
Yes, sir. Yeah, tricuspid showed increased variation, sir, respiratory variation.
How much of velocity variation is expected to be
40%,
significant?
more than 40%.
No. 40 is 25 and 35. So anything more than 25% on mitral and 35 on
Okay, sir.
30% on the right is good enough to call
Okay,
it
sir.
a respiratory significant
Okay, sir.
variation. More the variation, more significant it is, but
Yes, sir.
otherwise. Sohan sir, Majan sir, any other question before we proceed to sir's talk?
Yeah, it's actually the echo recording with the respiratory channel is important in this case.
Yes, sir.
I
Absolutely.
think that was not done. But definitely you have an idea means how to operate the respiratory channel on your echo machine because it is there with all the machines. It is important in these cases because the inspiratory and expiratory phase you are not able to judge on the means by seeing the patient only.
Yes, sir.
And E prime velocities, have you recorded this patient E prime velocities?
Actually, sir, the patient was not so much. I could barely get few echo recordings because he was getting discharged. He was very in a hurry, so that is why I could not get all the recordings.
Okay.
Yes, sir.
Okay. Majan sir, any questions, or I think we should thank Prarthi for her presentation, and then we can move.
She had presented excellently, so I think we can move ahead. There are no questions from my side.
Sohan sir, shall we end our presentation?
Yeah, definitely, sir. We can.
Okay, Prarthi, it was good presentation. I think you should focus rather than jumping every question to the credit question. You should focus every question as a simple question first. Okay, you know the subject, but then don't think of rarer causes, unusual explanations like the JVP between CCP, RCMP, simple things, PA pressure, same echo. So pericardial calcification. I mean, that's very simple thing to pick
Yes,
up
sir.
a constriction versus lack of it. Paradoxical septal bounce you spoke, which is rare, but calcification. But you did well. So
Yes.
well presented, Prarthi. And most important thing was that we wanted you to have a good exposure across the
Yes, sir.
board, and that I think has served the purpose. I hope this presentation helped you in
Yes, sir.
gaining the confidence in presenting clinical cases.
Yes,
So thank you very
definitely.
much, Prarthi.
Thank you, sir.
Thank you. And with this, now I would invite Professor Dr. Sohan Sharma sir, who's professor of cardiology at SMS Medical College, Jaipur, for his presentation on how to differentiate from clinical cath and echo between the RCMP and CCP, which is a commonly asked viva voca. So, Prarthi, if you can end your presentation, we
Yes.
can have sir share the slides. Over to you, sir. Thank you. Thank you
Yeah,
for
thank
joining,
you.
and over to you.
With such a nice discussion of the case of Prathi, I think there is no more points to tell you because everything from the presentation to the examination to the eco findings we have discussed in our case also. I'm going to share my presentation. Yeah. Are you able to see it? Just a minute.
Yes, sir. If you can make it full screen and start with the first slide. This is 16 slides, sir. Yeah. Perfect, sir. Yes, sir, we can see, sir. Please proceed.
Just one, sir. Actually, there is a yeah. Yeah, it's a differentiation between CCPs versus RCMP. There's a clinical, eco, and cath features. So as we have discussed, am I audible, Kamal sir?
Yes, you are perfectly audible, sir. Please go
Yeah.
ahead.
As we have discussed, in the Western world, the most common etiology is idiopathic or post-surgery or post-radiotherapy. While in the India, it's tuberculosis that is the most common. So it's a constrictive pericarditis on the basis of etiology. In the clinical examination, definitely etiology comes in our mind. Means what are the common causes of the constrictive pericarditis or restrictive cardiomyopathy? So these are the common causes as far as India is concerned. These are the uncommon causes, but seen in certain subset of the patients, like neoplastic uremia, vasculitis, as we have discussed in our case, also rheumatoid. It is seen in rheumatoid arthritis, SLE also, infectious, post-myocardial infarction, post-trauma, drugs like procainamide, methotrexate, paclitaxel, hydralazines, and hemopericardium or hemorrhagic disorders. These are the rare causes of the constrictive pericarditis that sometimes need an evaluation. This is a slide showing the causes of restrictive cardiomyopathy, like infiltrative, like amyloidosis, Hurler's disease, Hunter's disease, Gaucher's, and sarcoidosis. Storage disorders, like Fabry's disease, iron overload cardiomyopathy. So in the presentation like in Fabry's disease, the cardiac manifestation present in 30s of the life, later in females. If there is iron overload cardiomyopathy, there is skin pigmentation, diabetes, liver dysfunction may be the associated symptoms. If secondary to the hematological disorder, there is history of hematological disorders is there. If there is non-infiltrative cardiomyopathy, again, there is possibility of scleroderma, idiopathic restrictive cardiomyopathy, or pseudoxanthoma elasticum. Endomyocardial fibrosis also came in the discussion, like it's seen in Kerala, EMF hypereosinophilic syndrome, carcinoid syndrome, drugs like hydroxychloroquine, ergotamine, methotrexate, and radiation-induced cardiomyopathy. These all are the possible causes of restrictive cardiomyopathy, and previously we have discussed the causes of constrictive pericarditis. So in the clinical picture, there is some clue on the cause of the disease. As far as the symptoms are concerned, these are the diseases that generally present as a right-sided heart failure, like pedal edema, as in our case, ascites. Patient may have difficulty in putting on belt and abdominal garments, which may leave skin impression. That is the history given by the patient. Abdominal discomfort because of the splanchnic congestion, tight collar due to the neck engorgement, some uncommon presentation or deceptive presentation like CHF pleural effusion, right atrial thrombosis, as commonly seen in restrictive cardiomyopathy, and hepatic coma. In restrictive cardiomyopathy, most conditions affect both right and left ventricles, so there may be sign of the biventricular failure is possible in restrictive cardiomyopathy. One thing I want to share here, because these all slides I make from the SPOTIC, that is the book of the constrictive pericarditis, and I try to make references as standard as possible. So, what is ascites precox? It's a constrictive pericarditis. It is out of proportion to the pedal edema. Generally, it precedes the constrictive pedal edema. It occurs usually earlier than the pedal edema. What are the suggested mechanism? It's a partial constrictor effect on at least one of the hepatic vein as it enters the right atrium. Relatively high atrial pressures compared to other causes. Hypoalbuminemia because of protein losing enteropathy. Cardiac cirrhosis. Increased capillary permeability and impedance to lymph flow. as ascitic fluid accumulation initiated by the liver leaf, which exudes due to the high hepatic venous pressure. That is means weeping of the liver that we have already discussed. Symptoms due to the high central diastolic pressure, if it is more than 15 mm of mercury, dyspnea, easy fatigability. Dyspnea, the mechanism somewhat different from the left-sided heart failure we have discussed in this slide. Easy fatigability, cough, occasional orthopnea, rarely platypnea. Orthopnea and platypnea is rare in both CCPs and RCMP. What is the mechanism of dyspnea? Cardiac output cannot rise adequately with sufficient exercise. Relatively fixed and reduced stroke volume. Pleural effusion, usually bilateral. Diaphragmatic movement restricted by the ascites. These are the possible mechanism of the dyspnea in constrictive pericarditis, as this was also discussed in our case. On the physical examination, important is that mild tachycardia is the rule because of the heart rate into stroke volume improves the cardiac output in these patients because of the fixed stroke volume. More chronic cases may be accompanied by atrial fibrillation, nearly seen in 22% of the cases. BP is normal. Pulsus paradoxus is seen in effusoconstrictive variety or lung disease, but it is not seen in restrictive cardiomyopathy. Pedal edema may be there. Ascites, pale, cool extremities with peripheral cyanosis, and jaundice may be there. Pulsus paradoxus, how to see? We have also discussed in our case. First, there is a intermittent. First sound appears on the first heart sound on the step. Then after that, there is intermittent heart sound during the expiratory phase only, and after that, there is both phases of the respiration. You able to hear Korokov sounds. So difference between the first heart sound and continuous heart sound is the pressure difference that is known as pulsus paradoxus. On general physical examination, jugular venous distension is a hallmark. May not be seen if the patient is on diuretic due to the vasoconstriction. Venous pressures are generally high. Sharp X and Y descent. In RCMP also it may be seen. Jugular X descent occurs approximately with the carotid peak. This timing is very important because to identify the timing of the event, means X descent when occurs the Y descent. And Y descent coincides with the S3 and concomitant diastolic precordial thrust. Retinal veins may be engorged because of the congestion. Small sign is generally present in constrictive pericarditis, not in restrictive cardiomyopathy. Liver is palpable because of the congestion. Ascites is present and spleen if portal hypertension is there. On physical examination, palpation is quiet with no point of maximum pulse or paradoxical systolic retraction of the chest wall. Diastolic thrust coincides with the loud abnormal S3 sound with knocking quality. It is not seen in RCMP. Generally, S4 may be heard in the RCMP. If LV dysfunction develop, then if means ventricular dysfunction develop, then there is a possibility of the S3 in restrictive cardiomyopathy. S1 is normal. S2 is generally fixed split or inspiratory widening of S2 because of the early A2 component. Important thing is that bedside timing identifies certain events like abnormal S3 follows usually a well split S2. It follows the carotid pulse peak, whereas S1 precedes the carotid peak. This timing I will discuss later on the hemodynamic part. Audible S4 in RCMP. CCPs, ECG we have discussed in case also. Generally, there are not specific features about the CCPs and RCMP, but usually only STD changes and P-wave abnormalities is seen in ECG in CCP. While in RCMP may have QRS changes, abnormal Q waves or conduction defects may be there. X-ray, pericardial calcification is one point that helps in the diagnosis of CCP is seen in nearly 1/3 of the cases. Calcification is best seen on lateral X-rays, appearing in sheets, hoops, bands, and irregular bands. Calcification is heaviest over the right heart, the diaphragmatic surface directly under the left ventricle, and the AV groove, especially on the left side. While in the RCMP, there may be chances of pulmonary congestion. Along with that, there may be biatrial enlargement in RCMP. So till now we have discussed the etiology point, and on examination, history point, symptoms. On examination, JVP, and after that, systemic examination. There's two slides on the ventricular interdependence, because these come regularly in discussion. What is ventricular dependence? This is the normal pattern. Normally, because of spontaneous respiration, RV filling increases. After that, RV systolic stroke volume increases, and there is a pulmonary transit time. That pulmonary transit time leads to increased LV filling 2 to 4 beats after the phase of respiration, and after that there is increase in LV stroke volume. So there is a this is in series, means first there is increase in RV volume with inspiration, and after that, after few beats, there is increase in LV stroke volume. This is the normal phenomena. While in constrictive pericarditis, what happens? Because of the constriction layer around the heart, there is a parallel ventricular interdependence. What does it mean? When there is a filling in the RV during the inspiration, it causes shift of the interventricular septum towards the LV side. That's why there is on the echo also, you may able to appreciate ventricular shift of the LV on the M mode also, or on the 2D echo mode also. And this LV interventricular septum shift towards the LV side leads to decrease LV filling during the inspiration, and because of this decrease, there is fall in blood pressure also. In the expiration, the reverse happens. So this is known as parallel ventricular interdependence. Before going into the detail of the echo finding, this picture taken from the Naveen Nanda sir's book. It's showing the drawing of hepatic venous flow with simultaneous hemodynamic events in the heart. See there, this is the A wave, X descent, V wave, Y descent, and again there is a atrial wave. So X descent is occur during the systole, and this A wave occurs nearly 80 milliseconds after the P wave in the ECG, and this X descent after the QRS complex, and this V wave is seen at the end of T wave. This is the thing how you time on the echo also, because this is very important things to identify on the echo, means which wave comes at what time. So after the P wave, nearly 80 milliseconds, there is a wave. After the QRS, there is a X descent, and just after the T wave is the V wave. Actually, V wave occurs at the end of the systole, and it crosses this ventricular systolic pressure crosses at the peak of P wave. After that, there is a diastolic phase. There is a Y descent, that is the early diastolic filling period, and there is delayed, slow diastolic filling period, and after that there is a atrial filling period because of the atrial contraction. So in this RA pressure tracing, once this thing clear in your mind, then you see this is the hepatic venous Doppler. This is the systolic wave that coincides with the X wave, and this is the diastolic wave that is coincides with the Y descent in the Y descent, X descent, and Y descent. So Y descent in the JVP or RA pressure tracing. So Y descent coincides with the diastolic wave, and X descent with the systolic wave. Similarly seen in superior vena cava Doppler, and if we put a tricuspid valve Doppler or mitral valve Doppler, this E wave coincides with the Y descent. Y descent coincides with the diastolic wave in hepatic vein, superior vena cava Doppler, and E wave at the mitral or tricuspid flows. Now this is the flow in the pulmonary vein. Again, the same thing. The systolic wave coincide with the X descent, and diastolic wave coincide with the Y descent, that is with the E wave. This is very important thing to time the events. So this is the drawing of the pulmonary venous flow with simultaneous hemodynamic events in the left side of the heart. This is the recording. This is the recording, normal hepatic vein Doppler. See how you time it. This is a P wave. There is a atrial contraction. This is a QRS complex, and this is the systolic wave. And after that, this is the diastolic wave. So this is the thing you means time the events according to the ECG. This is very important to say systolic reversal, diastolic reversal, expiratory, inspiratory reversal. This is the tracing of the right upper pulmonary vein and LV inflow during the inspiration and expiration. See, this is the systolic wave, this is the diastolic wave, and diastolic wave come with the E wave. This in this lower diagram, this is the E wave coincides with the diastolic wave. And there is not much respiratory variation in a normal person between these waveforms. So this is the echo M mode at IBC in both CCPs and restrictive cardiomyopathy. IBC is dilated and there is no respiratory variation. See, there is a M mode and there is a ECG tracing, and this lower curve is of the respiratory channel. So little or no change in the diameter during the respiratory cycle, indicating this is a right-sided heart failure. In the presence of normal LV function or normal biventricular function, if IBC is dilated, the first thing should be come in your mind. Maybe you are dealing with the case of diastolic dysfunction. It's a CCP or RCM. Yeah. This is the M mode at mitral level. Again, this is important to identify the septal bounds. That is movement of the septum during the movement of the septum during the cardiac activity, and posterior LV and pericardial flattening throughout the diastole and thickening of the pericardium. This may be appreciated on the 2D echo mode also and M mode also. While in the right side, this is a restrictive cardiomyopathy. You see there is an increased thickening. There is an interventricular septum thickening is there, and there is no flattening observed in the posterior left ventricular wall, and pericardium is normal. And in the restrictive cardiomyopathy, you may also see biatrial enlargement that is not seen in constrictive pericarditis at the M mode also or at the routine 2D echo mode also. This is the pulse wave Doppler at the mitral valve level. You see, this is the pulse wave sampling, ECG, and these are this is the respiratory channel. Are you able to see this marker? This is the respiratory channel, and this upward going is the inspiration phase, and this downward is the expiratory phase. So transmitral flow velocities showing sharp inspiratory decrease or expiratory increase on the left side of the heart. That is, if it is more than 25% or more than 25% on the left side or more than 35 to 40% on the right side. So this left side of the picture is for constrictive pericarditis. There is a respiratory variation that is seen by the height of the E or E wave. While on the right side of the picture, there is not much changes in the transmitral flow velocities with the respiration. Almost same in all the phases. And also there is E height is more than the A height. This is the TDI at the mitral valve. You see the value of medial annulus E prime velocity is 14.5 centimeter per second. So if it is more than 8 centimeter per second, it shows it's a high TDI values, and this is known as annular paradox. And lateral annulus is usually higher than the medial annulus, while in this case it is lesser than the medial annulus, that is known as annular reversus. Both these features are seen in constrictive pericarditis. This is the lateral annular velocity. This is a 12.6 centimeter per second. So it is lesser as compared to the medial annular velocity. While lateral and septal mitral annular tissue Doppler showing decreased E velocity in the cases of restrictive cardiomyopathy. So this is the E velocity. It is less than 5 centimeter per second. And this is the lateral annular velocity. It is somewhere around 6 or 7 centimeter per second. So on the M mode, you able to identify pericardial thickening and septal bounds. And after that, you do a Doppler study, pulse wave Doppler of the mitral valve and tissue Dopplers. These are the pulse wave at the tricuspid, aortic, and pulmonary valve. There is change. Again, there is a respiratory change in the velocities. Transaortic and transpulmonary flow velocities also change with the respiration. This is the pulse wave at the pulmonary vein level. In CCP, increase in the diastolic flow velocities. Say there is a diastolic flow velocities increase with atrial reversal is increased with the expiration. While in the RCMP, there is not much change with the respiration. Hepatic vein, we have discussed in our case. There is a hepatic vein flow reversal. What does it means? These are the respiratory channel, and this is the ECG. So greatly decrease in diastole expiration and increase diastolic reversal. How you identify the systole and diastole? You first, if you recollect that diagram of the timing of the events, this is the P wave, and after P wave there is a QRS complex, and after the QRS complex there is a X descent. Possibly, this is the X descent, the systolic event. So with the X descent, there is a systolic wave, and with the Y descent or in the diastolic phase, there is a diastolic wave. So it's a diastolic flow reversal. So there is little bit delay in the timing. So this is the diastolic flow reversal in the hepatic vein is seen. So diastolic flow reversal in the expiratory phase. This is the expiration just started. This is a downward tracing is of respiratory channel. It's a expiratory phase. So hepatic vein pulse wave Doppler showing increased inspiratory flow velocities and inspiratory diastolic flow reversal in the case of restrictive cardiomyopathy. This is the case of restrictive cardiomyopathy. There is an inspiratory flow reversal. This is the reversal of the flow. It's an arrowhead. This is one important slide of pulse wave at the SVC. This helps to differentiate between the COPD and constrictive pericarditis. In the if you put a Doppler in the SVC, pulse wave Doppler, with the inspiration, there is significant flow seen in the SVC in the cases of COPD, while in the constrictive pericarditis, there is not much change with the phase of respiration at the SVC in constrictive pericarditis. This is newer imaging modality that help to differentiate between the constrictive and restrictive cardiomyopathy. This is particularly useful for RCMP. This is a case where there is typical apical sparing. This red part is the normal systolic contraction, while blue and lesser like pink is abnormal ventricular contraction. These are the modalities available to differentiate of the myocardial performance. So this picture is taken from Spodek. This is the schematic presentation of the constrictive pericarditis with the phase of respiration. It's inspiration, expiration. RV inflow increases with the inspiration. RV flow decreases with the expiration. Hepatic vein flow reversal. In the Spodek, it is written. There's much of the time you may not be able to appreciate hepatic vein flow reversal. LV diastolic pressure is same throughout the phase of the respiration, while pulmonary capillary wedge pressure increases during the expiration and decreases during the inspiration. Pulmonary vein flow reversal, pulmonary vein flow systolic wave is lesser than the diastolic wave, and atrial reversal is seen. And LV inflow variation is also seen. LV inflow variation in the inspiration is less, and the expiration it is more. So these all echo finding is there. As far as sensitivity and specificity is concerned, there are the septal bounce, change in mitral E velocities, mitral E prime velocities more than 9 centimeter, and lateral and medial E prime velocities ratio, and hepatic vein diastolic reversal. If all these points are present, then the specificity is increased, but sensitivity becomes less. So the positive predictive value of the diagnosing the condition is more. Once you have make a diagnosis on the echo, then you advise the patient either CT or MRI to confirm your diagnosis of the pericardial thickening or involvement of the myocardium, because MRI is important investigation to differentiate between the myocardial involvement and pericardial involvement. So pericardial thickness, if it is more than 4 mm, it definitely differentiate between constriction and restrictive cardiomyopathy. If it is more more than 6 millimeter, then it adds great specificity. MRI helps in myocardial diseases in RCMP. Now coming on to the cath hemodynamics. These are the various pressure that should be measured. This is the tracing of constrictive pericarditis. This is on the right side, this RCMP. You see there is an increase in diastolic pressure, number one. There is a dip and plateau configuration. There is a Y descent, X descent. X descent is not seen on right side, but Y descent is there, and dip and plateau configuration is also there. This is elevated diastolic pressures with rapid filling LV, rapid filling wave, and there is a dip and plateau configuration. In the right and left ventricle, elevated and equalized diastolic pressure in all the cardiac chambers. In RCMP, more than 5 mm difference is there, but in the CCP it is not there. Dip and plateau and square root sign. Elevated RV systolic and diastolic pressure, more in RCMP. RVDP is more than 1/3 of the RVSP, but it is less than 50 mm mercury in the case of CCPs. And RCMP, RVDP is less than 1/3 of the RVSP, but RVSP is more than 50 mm mercury. And height of LV rapid filling wave, if it is more than 7 mm, it is strongly suggest diagnosis of constrictive pericarditis. If it's less than that, then it is in favor of RCMP. Respiratory hemodynamics, there is no fall in the RA pressure with the inspiration. Simultaneously, LV and PCWP pressure tracing we've seen. There is a variation in CCPs, but it is not in RCMP. And ventricular interdependence, we see in the next slide. What is that? It's a ventricular discordance is seen, then it is seen in CCP. If it is not there, it is in RCMP. This is the difference between the pulmonary capillary wedge pressure and LV diastolic pressure. With the expiration, it is difference is there, but with the inspiration, that gradient is lost. If it is there, then it is suggestive of CCP. But if it is maintained in both phases of the respiration, then it is the restrictive cardiomyopathy. This is the ventricular discordance. If you see, this is the inspiration, this is the expiration. In the expiration, LV pressures increase, while RV pressure decrease. In the inspiration, LV pressure decrease and RV pressure is increased. Along with that, there is LV rapid filling wave. It is more than 7, and there is dip and plateau configuration. So this discordance means RV is decreasing, LV is increasing, is seen with the CCPs, and while in the RCMP, both moves in the same direction. So this is this is the indicator of ventricular independence, and systolic area index is calculating by this curves, and if it is less, then it is suggestive of CCP. If it is more, then it is suggestive of RCMP. These are the diagnostic accuracy of the various hemodynamic parameters. Means if difference between diastolic pressure, if it is less than 50, these are the sensitivity and specificities. RVSP and RV and diastolic pressure, RV-EDP and RV-SP ratio, if it is more than 3, they are more sensitive. PA pressure is less, sensitivity is 93%, and LV rapid filling wave, it is more than 7 mm mercury, sensitivity is 93%, and positive predictive value is 61 and negative predictive value is 62. Then respiratory change, respiratory variation in hemodynamics. In this, interdependence is the most important. This is 100% sensitivity, and systolic area index that we have just seen, it is 100% specific to diagnosing the CCP and RCMP. So again, just a quick reminder about the hemodynamic difference. Prominent Y descent seen in CCP, it's variably in RCMP. Equalization of left and right-sided pressure in CCP, there is a difference of 3 to 5 mm mercury in RCMP. Square root sign is present in both, but commonly present in CCPs. Filling pressures are more in RCMP, while in the more than 25 is rare in CCPs. PA pressures are elevated more in RCMP. RV and diastolic pressure upon RV systolic pressure ratio is more than 1/3, while in RCMP it is less than 1/3. Pulmonary capillary wedge pressure and LV diastolic gradient in expiration, that we have seen in our slide, it's present in CCP while it is absent in RCMP. Interdependence is discordant in CCP while it concordant in RCMP. And LV rapid filling wave height is more than 7 in CCP, is less than 7 in RCMP. So in the next 2 or 3 slides, a summary what we have discussed. First, we have discussed the etiology like tubercular, viral, post-radiotherapy, post-surgical, and idiopathic in constrictive pericarditis. Restrictive is infiltrative, non-infiltrative, storage disorder, and endomyocardial disorders. Symptom because of the right side heart failure in both the condition, but because of the biventricular failure is seen in restrictive cardiomyopathy. In the signs, JVP, definitely pressure is elevated, but prominent Y descent in JVP is seen commonly in constrictive pericarditis. The small sign is in constrictive pericarditis, pericardial knock in constrictive pericarditis, broadband sign or retracted apex is seen in constrictive pericarditis, and paradoxical pulse is seen in 1/3 of the cases of the constrictive pericarditis. These signs are present that favors the constrictive pericarditis, but prominent Y descent is variably present in restrictive cardiomyopathy, but other signs may be absent. ECG means some clue, but not much helpful in diagnosing. Chest X-ray calcification sometimes seen while it is absent in restrictive cardiomyopathy. Echo findings, it's important to echo. There's a pericardial thickening, septal shift or septal bounce, pericardial effusion, and systolic function is usually normal in constrictive pericarditis. Biatrial enlargement, ventricular hypertrophy, and myocardial speckling and systolic function may be normal or reduced in restrictive cardiomyopathy. M mode, septal bounce is the again posterior left and pericardial flat, posterior LV wall, and pericardium is flat throughout the diastole, while this is absent, septal bounce is absent in restrictive cardiomyopathy, and posterior alveoli and pericardium not flat in diastole. In the Doppler, MR or TR is commonly seen in restrictive cardiomyopathy, not in constrictive pericarditis. EA ratio is more than 2 in both the condition because of the diastolic dysfunction. Respiratory variation is seen in constrictive pericarditis at the mitral valve level, at the tricuspid valve level, and higher velocity is seen at the mitral level in constrictive pericarditis, while it is low in restrictive cardiomyopathy. Annular paradox and reversals seen in CCPs. Both velocities are reduced, but lateral more than septal in RCMP. Hepatic vein flow reversal greatly decreased in diastolic expiration in CCPs, while systolic more than diastolic forward flow in RCMP. Pulmonary vein flow expiratory increase during systole and diastole, while in expiratory increase during the diastole in RCMP. Speckle tracking, that is latest advancement in the echo, normal longitudinal and decreased circumferential restoration, while decreased longitudinal and normal circumferential restoration in restrictive cardiomyopathy. GLS, LV septum is more than free wall, that is expected in the case of constrictive pericarditis, that is global longitudinal strain, and apical sparing is seen in restrictive cardiomyopathy. These are the pressure tracings we have just discussed. Diastolic pressure and LV and RV equalization. Ventricular interdependence is present in CCPs, not in RCMP. Systolic area index is more than 1.1, less than 1.1 in RCMP. PA pressures are usually normal, but it is usually high in RCMP. Ventricular filling pressure more than 25 is rare in CCP, is common in RCMP. Square root sign is generally present in CCP, but variably present in RCMP. Respiratory variation in left-sided and right-sided pressure and flow is exaggerated in CCPs, it's normal in RCMP. And LV rapid filling wave is more than 7, it is less than 7 in RCMP. After this CT and MRI, we have just discussed, angiography may be normal in both the conditions, and endomyocardial biopsy may be needed sometimes to differentiate between the myocardial involvement in restrictive cardiomyopathy. In last, we've done all these things. Sometimes there is still a confusion in a diagnosis. That is one slide I have taken from the SPOTIC. Positive diagnosis essential. Negative test for one does not imply probability of the other. This is important. Means this is negative, then the chances of RCMP is there. It's not there. It's not like that. There may be some positive findings of the diagnosed condition may be there. Both may coexist like post-radiotherapy. Physical examination may be unhelpful. Hemodynamics may be unhelpful. So what is helpful? Echo, Doppler plus CT scan is nearly always make the diagnosis. So if you confront with the case of CCP or RCMP, echo, Doppler and CT scan are important mode of investigations that makes that is helpful in diagnosing the condition. eventual endomyocardial or pericardial biopsies, sometimes inescapable. So this is all about my presentation. Kamal sir.
Thank you, Dr. Sohan Sharma, sir. Beautiful presentation. You've done a lot of efforts. I can see that you have compiled it from not only sporadic but also all the possible sources, including Jack, clinical case scenarios. I think I could see some slides even from my book. So you've actually gathered it from all across. It must have taken a lot of efforts. Thank you very much, sir. And I think it was very extensive and beautifully covered, practically covering everything, all the aspects in differentiating. I think this one lecture is good enough for anything that can be asked under the sun in differentiating RCMP from CCP. So, Dr. Ajay Mahajan, sir, any comments?
It was a very excellent lecture, and I need the copy of this lecture. Actually, all students should keep this copy of this
Yes,
lecture.
sir. I was also intending to ask the same.
Hmm.
Beautiful lecture.
Together
Beautiful.
I mail to you. You just share the mail address to me.
We'll send you.
And
We'll send you.
definitely, because I wrote a reference paper, reference number also, so that you can
Right.
tally
Yes, yes, yes. We could see that. And that is the reason I'm
detail.
saying that it is something that you yourself have made. That's how one can differentiate if it's prepared by the professor himself or by a student. This is prepared by you. We can see that. Beautifully prepared. All right. So, can we have our slides for the declaration of the next session? If Sohan Sharma sir can stop sharing.
Yes, just
So that brings us to the end of the series 5. Aman, if you can share the program details. So this was the lecture series 5. We had a beautiful presentation on case constrictive pericarditis, and then Professor Dr. Sohan Kumar Sharma sir took us through clinical cath and echo features of differentiating RCMP CCP. Next session falls on 21st, and this is going to be interesting because practically now everybody is getting a case of young CAD. And I think it's important because young coronary artery disease is the biggest practice that everybody wants getting a degree practices. And that's why it was important that we always stressed, and our university was one that actually insisted that this should be included as one of the case presentation, because that's what all residents practice. So we'll be having Dr. Abhinav Agrawal from VMMC presenting on 21st November, a young case of CAD, and then we'll have Dr. H.K. Srinivas, who will take us to approach to a young CAD with Indian perspective, who's a professor from Jayadeva Institute of Cardiology from Bangalore, and then Dr. Ashwini Mehta will be talking about session on single antiplatelets and its scenario, director of heart failure program at Gangaram Hospital, New Delhi. And this is on 21st of November at 8 p.m. again. So myself and Dr. Ajay Mahajan, we would look forward to have you all. Dr. Ajay Mahajan, sir, your closing words, and then we can close the session.
So these are very important sessions. Everybody should be there, and no one should miss these sessions because there is a lot of learning in this. So with this, I will stop here, and we'll have good night, and we'll meet on 21st.
Good night, sir. Good night, Sohan Sarvashar. Thank you.
Yeah,
Thank
good
you
night.
for being here.
Thank you.
Thank you, everyone. Good night. Take care. Bye-bye.
Thank you, sir.